everybody. Welcome back. We've had two great sessions this morning already. We're moving into our third. And again, we want to thank you guys for sharing your Saturday morning with us. We are during our next talk, if you do have questions that pop up, please put them in the chat. We'll do our best to get to them or make sure they get to the appropriate speaker if we're not able to answer them in that particular session. But our next session is going to be going over the diagnosis and staging of kidney cancer. And I'd like to introduce Dr. Benjamin Mon, who is an assistant professor of oncology at the University of Utah, Huntsman Cancer Institute. I'm going to turn it over to him to walk you through some of the information regarding kidney cancer.
Thanks, Sally. Let me get these slides pulled up. And back to the beginning. Okay, so it's really a pleasure to be here and help KCA with this meeting. It's such an incredible organization. Between all the advocacy that they do legislatively and research and patient education, et cetera, it's just really a pleasure to be here and help. So. I was trying to think of a way to present this information that would be the most helpful for all of you. And what I thought about doing was walk through at least the beginning of a patient that I've taken care of, and we'll discuss some of the terminology that can come up and some of the steps that go through, the diagnosis process to hopefully try and familiarize all of you with some of these key terms and give you sort of a little bit of a perspective of what I think of when I go through, helping a patient, from the very beginning, or any physician for that matter. So CH is a patient that I started taking care of a few years ago. At that time, she was a 60-year-old female, and she noticed that the reason that she came to sort of medical attention for this particular issue is that she experienced 4 months of this worsening fatigue, this unintentional weight loss, losing her appetite, and she also felt this progressive abdominal sort of fullness and pain, sort of bloating. She's she's retired now, but at the time she was employed as a secondary education teacher, and she was really struggling to be able to do her job. That's the degree of fatigue she was having. She would barely make it through school, come home, and really just sort of sleep all day. And anyway, so it was really a problem for her. So let's pause here and first sort of talk about some symptoms or some terms that you may come in contact with as you're reading, the notes from the physicians, through my chart or whatever the medical record is. So the first is hematuria. So this just means bloody urine. So, CH didn't have this particular symptom, but this is one of the common presenting symptoms that patients may experience because of the cancer growing in their kidney, in the urinary system. That can lead to bloody urine. So that's what hematuria means. So anorexia is a term that we're probably much more familiar with because there's a medical diagnosis, anorexia nervosa. But that's really sort of a separate issue. The term anorexia itself just means lack of eating, right, or not eating, right? And so, in the psychiatric definition, it's because of a psychiatric or mental illness that patients aren't eating. But in this case, it's the cancer itself that's making patients lose their appetite, and that's leading to this lack of eating or anorexia. So if you come across this term, in the medical charts, that's what it's referring to, not necessarily a psychiatric or mental illness. So another term is cachexia, and that just means wasting. So you perhaps have seen pictures of this or know somebody, but when you start wasting away from cancer, right? So cancer is a living tissue, so it needs energy to grow. And so it's stealing away that energy from your body. And because of that lack of appetite, patients have a very high energy need, but a very low energy or calorie consumption. And so the muscles start wasting away, et cetera. And so that's when people start looking thin and gaunt and et cetera. So that physical appearance is this term cachexia. And then finally, there's this term failure to thrive. And this is just sort of like a catch-all term that's sort of trying to describe a number of these items. And it just means that patients are dwindling and they're not physically thriving at home. They're getting weaker. They may be falling, they're having some of these issues like anorexia or cachexia, but they're just getting physically weaker, and that's this term failure to thrive. And that really encapsulates, so some of these terms certainly encapsulate what CH was experiencing: anorexia, failure to thrive. She hadn't reached that point of cachexia yet. So what do we do first? Well, we need to try and understand what's going on. Because of this abdominal pain, very commonly patients will have imaging done to try and understand if there's something structural or anatomic that's leading to these symptoms. So she had a CT of her abdominal abdominal region done. And just a very brief introduction of what we're looking at with the CT scan. So this isn't the most common way to view the CT scans. This is what we call a coronal view. So CH is standing here in front of us, and we're looking at a slice of her body top down. So on a CT scan, things that are dense, like bones, are going to be white. Also, things that have contrast in them are going to be white. And things that are not dense, like the air outside, are going to be black. And so here on her scan, I should have asked the IT people if you can see my mouse. Hopefully you can. But anyway, if you can't, just I'm outlining this area right here, this really big mass. And this is her cancer that has replaced her kidney on the right side. And it's just below the liver, which is right there at the top of the screen, on the top left part of the screen. So she was diagnosed with a very large mass. And so that leads us to this next set of terms that we need to discuss, which is diagnosis. So now that we see this very large mass, it makes us wonder, well, what is that, right? We need to come up with a diagnosis. And so when we're thinking about cancer, which because of this mass, that's the top thing on our list, this is really likely to be a cancer. One of the first things that we start thinking about is if this is a localized cancer or if this is a metastatic cancer. And the word metastasis just means spread. So, in this case, if the cancer originated from the kidney, metastatic kidney cancer would mean that some of the kidney cancer cells had spread to other parts of her body. And so the way that we understand if it's metastatic is by imaging the other parts of the body. So I'm not going to show you all of her scans, but she had a CT scan of her chest done, which it shows this spot right here. So this is the more common way of looking at a CT scan, where instead of we're looking at a frontal view, we're looking at sort of like a cross section of the body. So imagine she's laying on the table, we're standing at her feet staring into her body. And so at this particular part of her body, we're at that intersection between her lungs. That's where the little black stripes are along the bottom. That's the very bottom of her lungs. And then we're at the level of the liver. And so you can see there's this measurement at the bottom right side of the screen that if you look very closely, it says 26.1 millimeters. So that round circle there in the lungs shouldn't be there. It should look like the other side, right? The little small dots are normal and fine. That's the blood vessels coursing through. But that really big spot that's measured, that's not supposed to be there. So that's a metastatic site. So this is evidence that she has metastasis or distant spread of cancer. And so getting to the second part of our definition series here is this term staging. So staging is just a way for us to think about the extent of the cancer. How much of a problem are we really dealing with? So staging is typically divided up into 4 categories. And these aren't technical definitions that I put here, but conceptually, this is what we're trying to capture with or understand or define with these stages. So stage 1 typically is a localized cancer. It's contained within the organ where the cancer originated from, and typically it's of a small size. Stage 2 is also localized, more of a medium to large size. Stage 3 means it could be any size, but it's now regionally spreading. Maybe it's involving some of the nearby lymph nodes. Maybe it's directly invading. So for instance, in the case of kidney, directly spreading from the kidney itself to some of the fat tissue that's immediately around the kidney, right? So there's in some way, there's regional or direct spread of the cancer. And then stage 4 would either be it's inoperable because of how invasive it is into the surrounding tissue. It's just not feasible to cut it out, or more commonly, it's distantly spread, right? So in the case of CH, it's distantly spread to some distant site. So in this case, her lungs. That was she had multiple lung metastases. This was just one. So some other terms that are going to come up at this time is these terms right here: percutaneous biopsy and histology. As we'll get to in just a minute, trying to understand exactly what kind of cancer it is very important for us to understand the prognosis, but also the treatment options, because not all cancers are treated the same. So even though this is a very large mass in the kidney, and you would think, oh, for sure this has to be kidney cancer, actually, it doesn't have to be. There's other types of cancers that it could be. This could be various types of sarcomas. This could be unusual types of kidney cancers, like a Wilms tumor. This could be a classic or more common type of kidney cancer, like clear cell kidney cancer. This could be sort of an unusual presentation of a different type of cancer, like a lymphoma or something like that. So getting a biopsy and collecting a piece of the tissue to look at it under the microscope and understand exactly what it is very important to understand. And so the way that you collect that tissue is varied, right? One common way that's done is with what's called percutaneous biopsy. So this is a percutaneous, just means through the skin. So you're collecting a biopsy through the skin, right? Another way to collect tissue is in the operating room with surgery, to like go in, open the patient up and surgically cut out some tissue and collect it that way. But in these days, the most common way to obtain tissue is with a percutaneous biopsy. A number of you may have some familiarity with this, but in general, what that process looks like is you take a small needle and numb up the outside of the skin with an anesthetic, just like is used in the dentist's office, right? And then once the skin is numb, then you take the biopsy needle, which is similar, but it's just longer, so that you can get deeper into the body. Then you take the biopsy needle, and under typically ultrasound guidance or sometimes CT guidance, but with some type of imaging guidance, you direct the needle into the area that you're trying to biopsy, and then you collect the tissue directly through the biopsy needle. Once you collected the tissue, you retract the biopsy needle, you put a Band-Aid over the small needle hole, and observe the patient to make sure there's no bleeding, and then you're done. It's an outpatient procedure. But that's what a percutaneous biopsy is. And then by collecting that tissue, you're able to understand the specific histology, or the exact tissue of what kind of cancer that is. Some other key terms that are very important to understand in the diagnosis realm is benign versus malignant. So benign or malignant are terms that are describing tumors. So the word tumor literally just means abnormal growth, right? So anything that grows abnormally is a tumor. Not all tumors are cancers, but cancers are a type of tumor, right? So the difference is a cancerous tissue or malignant tissue means that it not only has abnormal growth, but it also has invasive, destructive potential. So a good example that I like to use to illustrate this is a wart, like on your finger, right? That's an abnormal growth. That's not normal, but it doesn't invade or destroy the normal tissue. It doesn't erode away and eat your finger right off. So a wart is a benign tumor, whereas something like kidney cancer is a malignant tumor. And so understanding if it's a benign process, because there are benign entities that grow in the kidney, like angiomyolipomas, for instance, et cetera, or oncocytomas. So understanding if it's a benign tumor or malignant tumor has a significant impact on how we think about that problem for the patient. And then, some other terms that come up in this way are the terms nephrectomy and partial nephrectomy. So nephrectomy is a term that means removal of the kidney, surgical removal of the kidney. And then obviously partial nephrectomy is where part of the kidney is removed. And in the context of this discussion, the part of the kidney that would be removed is the part that has the cancer in it. So sometimes patients obtain, tissue is obtained from the patient through surgery. So sometimes instead of doing a biopsy, we because the likelihood of cancer is so high, we bypass the biopsy step and we go straight to surgery, and then you cut it out, and then you can collect the tissue and solve the problem all at the same time. And whether biopsy should be done first or you should go straight to surgery is really dependent on the specific situation. I will say one thing that I think is worth a brief comment is about biopsy itself. Many years ago, it was felt that doing a biopsy could actually lead to seeding or spreading of the cancer, and it turns out that's not correct. So a biopsy is safe to do from that perspective. It doesn't lead to or cause or contribute to a spreading phenomenon. So over the last number of years, 10, 15 years, biopsies have become much more commonplace for aiding in the diagnosis of kidney cancer. And there's multiple ways of performing nephrectomies or partial nephrectomies. They can be an open procedure where you literally cut open, make a linear incision and open the patient. Then there's minimally invasive surgery techniques with either robotic or laparoscopic. And, each of those has importance and value. It just depends on the specific circumstances of what's happening with the patient, which is the optimal surgical approach to go with. And then finally, this term renal cell carcinoma. Renal just means kidney. So kidney cancer and renal cell carcinoma are synonymous. They mean the same thing. So I am definitely not an ornithologist. I am a very skilled oncologist, but I really don't know much about birds. But this is a beautiful picture, and I think it highlights a very important concept in what we're talking about today. So please don't ask me to tell you what types of birds these are. I have no idea. But as you can see, there are different types of birds in this picture. So on the right, you have a bird with a black head. It's got a smaller beak, and then you see some of these with more curved beaks, and then some that are pink in the background, and others that are white. There's a variety of different types of birds, and they each have different anatomies and structures and different types of foods that they eat and different geographies of where they travel and go, but they all behave distinctly different from each other. And the same is true for kidney cancer. So looking into and exploring this idea of histology a little bit more, it's important to understand that not all kidney cancers are the same. There's distinct and different types of kidney cancers. And this is not by any means an exhaustive list. I'm just highlighting a couple of examples here. According to the WHO, World Health Organization diagnostic list that we use for kidney cancers, there's over a couple dozen different types of kidney tumors now that are defined and described. Again, some are benign, some are malignant, but there's lots of different types. So again, I've just highlighted a couple of examples here for you. And as you can see, each of them look distinctly different from each other. Now, these are all sort of stained different colors, so ignore the color, right? That's artificial, right? That's not what they really look like. But if you look at chromophobe on the right, you can see that there's a lot of white space in there, right? There's a lot of clear cytoplasm that these have. And in contrast, and the same with clear cell. If you look at the clear cell, there's all this like white clear space in there. But if you look at papillary, for instance, there's really not a lot of white space. You can see like faint little parts, and that's where there's a lot of lipid deposits, et cetera, within the cell. But it's very much more filled with like all this proteinaceous material, this protein, right? So they're distinctly different types of cancers. And if you look at the incidence of all of these, the incidence is just the frequency that we see them. So like of all patients diagnosed with kidney cancer, what percentage are clear cell, for instance, or what percentage are papillary or chromophobe or renal medullary, or, but that's what incidence is. And so somewhere about 75% of all patients that are diagnosed with kidney cancer are diagnosed with a clear cell form. But clearly there are other types. So that's why I made clear cell sort of like really big, because it's the most common. And if you look at across the bottom, these are the classic altered DNA that are associated with that particular type of disease. So clear cell kidney cancer is really driven, excuse me, let me get that out of the way, are really driven by alterations in this gene von Hippel-Lindau, whereas papillary is driven by other types of genes, right? MET or fumarate hydratase, or chromophobe is other genes, et cetera. So each of these are biologically distinct and different from each other. So this is the other really important reason that we want to collect tissue for each patient, so that we can understand, first of all, is it kidney cancer? But not only is it kidney cancer, but what type of kidney cancer is it? Because that leads to a distinctly different prognosis, right? Each of these types of kidney cancers behave differently. And there are some distinct differences in how we treat each of these diseases. So that leads me to a topic that was discussed earlier that I think warrants some additional emphasis, and that's about genetic testing. So, okay, so we have this diagnosis, we figured out what it is, but it's important for many patients that it's become apparent over the last few years that we really should be doing genetic testing on many patients with kidney cancer. Excuse me. And so in this realm of genetic testing, before we talk about that a little bit more, let's explore what a couple of different definitions are, because this is really critical to understand, in my opinion. So there are what's called somatic or sporadic alterations that can happen in the DNA. These are things that are also another term that's used here is acquired. So these are alterations that occur in the DNA of a very specific cell, for instance, the cancer cell, right? And these are problems that are acquired over time, either because of chemical exposures, or for instance, smoking is one significant risk factor for developing kidney cancer, because the chemicals within the tobacco smoke get concentrated in the kidney as the kidney is trying to process and clear these chemicals from the body. And so those chemicals can then injure and damage the kidney cells and transform them into cancer cells. So these are things that are acquired over time, right? So, or another good example is sun, right? UV radiation from the sun can damage your skin and lead to skin cancers like basal cell carcinoma or melanoma. But these are somatic, sporadic, or acquired alterations to the DNA. And when we do testing to try and understand what specifically those alterations are, for instance, the VHL gene in clear cell kidney cancer, the term that we associate with that type of testing is called genomic testing. And now this is going to get a little bit, the terms are very similar, so it can be somewhat confusing, which is why we're talking about it here. But there's a second type of alteration to the DNA that can occur. And this is called germline or familial. And the type of testing that we do to understand those alterations is called genetic testing. So again, these two terms are very similar, but they are referring to distinctly different things. Genomic testing is referring to acquired alterations to the DNA, and genetic testing is referring to testing to look for inherited DNA alterations, right? Because we all develop, we all have DNA from our parents, from our mother and father. And so if we inherit altered DNA from the very beginning, then those alterations are present in all of the cells in your body, right? Whereas in contrast, these sporadic or somatic alterations are only present in those specific cells and whatever cells that they gave rise to, right? So, if you do some genomic testing on a patient with kidney cancer, and their clear cell kidney cancer has an alteration in VHL, if you test their hair cells or their muscle cells, you won't find that DNA alteration. In contrast, if someone has an inherited form of clear cell kidney cancer, you will find that altered VHL gene in every cell in their body, right? So these two terms are distinct and different. Now, why is that important? Because as you've started hearing, there's a lot of different types of inherited forms of kidney cancer. So for instance, for clear cell, there's an associated germline condition called von Hippel-Lindau disease or von Hippel-Lindau syndrome that can give rise to clear cell kidney cancer. For patients that develop papillary kidney cancer, there's a couple of different types that can give rise. You heard a wonderful example illustrating this of hereditary leiomyomatosis and renal cell cancer, also referred to as HLRCC. There's separately hereditary papillary renal cell cancer for chromophobe disease. There's Burke-Hogg-Dubé syndrome. So there's a number of different inherited conditions that can give rise to that specific form of kidney cancer. So it's important to do genetic testing for many of our patients with a diagnosis of kidney cancer. So back to CH. So we realize, so where are we in her story? Remember, we know that she's got this kidney mass that looks very suspicious for kidney cancer. And we can see that whatever it is, it's metastatic. So it's not a benign process, it's a malignant process because we see these metastases in her lungs. So we obtained a percutaneous biopsy on her to understand and confirm, is this kidney cancer and what type is it? So the most common type of, so the pathologist then gets this tissue, and a little bit like, with Easter eggs, they then dye the tissue a whole bunch of different colors, and each specific color will only bind to a specific protein. So that helps you understand what the proteins are within the tissue, and then that really helps you understand exactly what kind of tissue it is that you're looking at. So on this H&E stain, you can see all this vacuolated or clear areas of the cytoplasm. And then this specific test looking for carbonic anhydrase 9, that's all the brown coloring that you see everywhere else. So this highly expresses carbonic anhydrase 9. And so this combination is very commonly and really sort of exclusively seen with clear cell kidney cancer. So this helped us understand that her diagnosis was indeed kidney cancer, and specifically the clear cell type of kidney cancer. So now we understand what her problem is, and we also understand the staging or the extent of her problem. However, I want to show you this other beautiful picture. So I'm also not a botanist, but I do love trees. So I can tell you that these are sycamore trees. But as you'll notice, so these are all the same type of tree, right? They're all sycamore trees. But if you look carefully at them, they're all different, right? So they have branches coming off at different places. They're different sizes. So there are, even though this is all the same variety of tree, they're not all the same, right? They're distinctly different from each other. And that is also true with cancer. So even if two patients have the exact same diagnosis, even the same stage, right? So they've got the same extent of problem, those two patients will have different experiences because the biology of their respective clear cell kidney cancers, for instance, behave differently, right? And so, and you can see this in the clinic as well. So Danny Hang led this great effort with the international this international collaboration that we call IMDC. So they collected information across the globe from lots of different research centers to try and understand how similar or dissimilar patients' experiences are with kidney cancer. And so, and then we mapped this out. So let me walk you through this a little bit so that you can understand. So on the vertical axis there, it says probability. So this is probability of being alive at that specific time point. As you notice, the horizontal axis along the bottom. So this is how many months after they've started some treatment. So this was one of their original publications, so back in 2009. But this has been validated over the years with each new type of treatment that we've been using. But to come up with this, what they identified is that they picked out certain characteristics that seem to predict for a biologically more aggressive type of disease versus a less aggressive disease. And then they assigned 1 point for each of these things. Like, for instance, was their calcium elevated? Or, did they have an elevated neutrophil count, right? So there's all these different clinical factors that they found, and they assigned 1 point for each of those things. So if the patient has no risk factors, they have 0 points, right? That's the group in blue. Whereas if they're intermediate, it's the brown in the middle. That's if they have 1 to 2 of these factors. And there's a total of 6 of these factors, right? So if they have anywhere between 3 and 6 factors, then they're in that green sort of group. And as you can see, the patients, even with the same treatment, the patients have a different outcome or a different experience. Not everybody with favorable disease does better than everybody with poor disease, but you're much more likely to have a more aggressive disease if you fit into this poor group, right? So as we can see, it's not only important to understand the specific type of kidney cancer, but it's also important to try and understand in a more specific way what the biology is for that particular patient. Because understanding how aggressive or not aggressive the cancer is really helps us understand or individualize their treatment for that patient. So as we are initially interacting with a patient, these are a number of the things that we're starting to think about. What's their diagnosis, right? Is this cancer? Is this malignant? Is this benign? What's the extent or staging of the cancer? What are the particular biologic factors pertinent for this cancer? So far, a lot of those biologic factors are I would say somewhat crude things. They're very helpful, but they're not as precise as we ideally would like them to be. So there's a lot more work going in to further refine this IMDC model using a lot of molecular characteristics. So that's something that we're not there yet, but we're in the process of working on and improving. So getting back to our patient, so in conclusion, what is her prognosis, right? What is our best sort of perspective or guess on how aggressive the biology of her cancer is, and what are her potential outcomes of how this might play out for her. So we know that she has metastatic clear cell renal carcinoma. It's stage 4. And if we calculate her IMDC score, which I didn't go into all the details of that for you, but conceptually, I think it's important to understand what it is. Her IMDC score is 4, which categorizes her as poor risk. So we're going to be thinking about trying to treat her as aggressively as possible to not only improve her quality of life, because remember, she had a lot of those really challenging symptoms to begin with, but also to prolong her life. We want to simultaneously accomplish, if possible, both outcomes of improving her quality of life and prolonging her survival. So those are some of the key concepts that I think of, and I try and go through, with patients when we're first seeing them, and to understand the diagnosis and the prognosis. So with that, I just wanted to pause and see what questions I might help all of you with in trying to understand this terminology or the thought process as we go through this part of the sort of individual patient experience.
All right, well, I will help foster some of these questions over to you. We actually have a wonderful question that started out bright and early this morning from Romania. Given the difference in some of these similar types of tumors, but yet still having differences, what goes into determining recurrence risk, especially for some of these smaller tumors, like less than 3 centimeters?
Yeah, that's a really good question. So ultimately, it's always the biology of that cancer that's going to drive the outcome, right? So if you think about it, looking at the size of a cancer is not a perfect way of understanding what the biology is, but it's one way that you can try and determine the biology, right? Because maybe in scenario 1, the tumor is only 2 centimeters because it's been very, very slowly growing over a long time. And so even after a long time, it's still only been able to get up to 2 centimeters. However, in contrast, in scenario 2, maybe for whatever reason, the patient had a CT scan, for some other reason, and you found that 2 centimeter tumor, but it's only barely started to grow, but it's growing very quickly, right? Just using a CT scan and size measurements, you don't know which of those two scenarios is really playing out for the patient. So that's why I say, just trying to understand biology based on size is imperfect. It's helpful, but it's imperfect, right? What we found through looking at a large number of patients is that patients with a small tumor, so like 1 centimeter, 2 centimeters, even 3 centimeters, patients with a small tumor, most of the time are in scenario one. Just because of probability, most of the tumors that size are in the more favorable sort of biologic side of the spectrum. And so size can be a very helpful tool to try and understand the biology of the cancer. So, and again, it's all about understanding the biology, because if someone has a very, very slow growing cancer, then depending on that person's age, their other medical problems, you may only want to do surveillance and just watch it, because if it's growing so slowly, and maybe that patient is never going to be harmed by that cancer being there, right? Whereas in contrast, if the patient's really young, even if it's growing slowly, then over that patient's lifetime, maybe they do need treated. So size is one very important way that we try and understand the biology and therefore the prognosis for an individual patient. Now, part of the question also was, what about individual histologies? Does that also play into how we think about the prognosis for a patient? And the answer is yes, because we know that each specific histology has, in general, different growth rates, right? So, for instance, papillary, it's not always slower growing on the comparative spectrum, but it tends to be somewhat slower growing. Or chromophobe is another great example than, say, clear cell kidney cancer. In contrast, some diseases like translocation carcinoma or renal medullary carcinoma or collecting duct carcinoma, those tend to be even more aggressive than clear cell kidney cancer. And so how we think about these is different, right? So if someone has a 2 centimeter chromophobe, kidney cancer, we're likely going to think about that much differently than someone that has a 1 centimeter renal medullary carcinoma. Like a 1 centimeter renal medullary carcinoma is almost always going to be recommended to be resected, just because that biologically is typically so aggressive. So it's a bit like a puzzle, right? Like a jigsaw puzzle. None of these things that we use, size, histology, et cetera, none of these perfectly tell us the whole picture of the biology. And so the more pieces that you can put together, the better you can understand the entire picture.
Absolutely. So definitely not an easy answer. There's no one thing that goes into determining recurrence risk for sure. We have multiple questions actually coming in about the most appropriate sort of follow-up scanning. Are PET scans useful, especially in distinguishing from damaged tissue? Are CT scans enough? Do you need brain MRIs? What's the best way to sort of do some of the follow-up imaging for these patients?
So the follow-up imaging depends a lot on what the stage is. So if someone has a small localized kidney mass only, they don't need brain imaging. But if they have metastatic disease, it's generally recommended to get brain MRI imaging on all those patients, because somewhere about 25% of clear cell kidney cancer patients will have a brain metastases. Again, that means 75% of patients don't, but that's a high enough number that we recommend everyone get brain MRI testing. In terms of what is the optimal type of cross-sectional imaging, CT scans, PET scans, et cetera, usually it's recommended that a CT scan is optimal. And that's because the PET scans, there's a reasonable percentage of the time that they are what we call a false negative, right? The patient really does have a problem, like, for instance, a distant metastases, but it will not be captured on the PET scan. So a PET scan is more sensitive than a CT scan for some cancers, and it's less sensitive than a CT scan for other cancers. And so in the case of kidney cancer, it tends to be in the less sensitive category. Now, if you really want to get more technical about it, there is a CT scan that's done with every PET scan these days. So the more accurate term is it's a PET CT scan, but it's a low resolution CT scan that's done almost always. And so it's typically better for kidney cancers to just go with a high resolution CT scan.
Talking about staging, can your stage change throughout your treatment, or specifically once you're labeled stage 4, is that it? Even if, they sort of radiate away the metastases, are you still always going to be stage 4?
Yeah, so it can change over time, and the easiest way to understand this is if someone's diagnosed initially with, like, say, stage 2 disease, right? So it's localized, and then subsequently their cancer recurs, and then they become stage 4. We typically never it never goes the other way, though. You don't start out stage 4 and go the other way. Although technically it can in this particular instance, because immune therapy for some patients can be immune therapy is a particular type of treatment that we use, or category of treatment that we use for many patients that have stage 4 disease. And for some patients, that can be so potent or effective that they can actually be cured of their metastatic disease. So in those patients, they technically would be downgraded, right? You would go from stage 4 to cured, right? So, but for the most part, it only goes one direction. It goes from one, or it goes up. It never goes down.
Okay. Great. When we think about at like earlier stages, especially, you can have one tumor in the kidney, you can have multiple tumors in the kidney. How common is it to have multiple tumors in the kidney, especially for like the lower stage people?
For patients that have sporadic kidney cancer, it definitely happens, but it's less common. For patients that have inherited forms of kidney cancer, that's almost always that is what happens, right? So it depends if it's sporadic versus inherited forms of kidney cancer.
And then you were talking about regional.
I guess, sorry to interrupt. One other thought that just occurred to me, but it is very common for patients to have a mixture of benign tumors in the kidney and also have, their malignant or cancer in the kidney as well.
Great. I did also want to reiterate that we do have other questions that we're probably not going to get to during the session, but we're going to do our best to get some physicians to review them and get back to you. So don't feel like we're not answering them. We'll just probably do them offline and reach out to you. One of the last questions was talking about stage 3 versus stage 4 and regional versus distant metastases. What if somebody starts out with a tumor in one kidney and then it starts to find a tumor in the other kidney? Is that a metastases because it's on the other side of the body, or is that regional? What would you consider that?
So technically that would be an example of metastasis, although, for whatever reason, kidney cancers rarely spread or metastasize to the contralateral or opposite kidney. Almost always when that occurs, it's a brand new kidney cancer that's developed in the opposite side. So in that case, you would have one localized kidney cancer and a separate metastatic kidney cancer.
Great. Looks like we are right at like about 10 seconds left here. So I definitely want to thank Dr. Mann for his talk today. Dr. Mann, do you have anything else that you'd like to add in summary before we switch to our next session?
I just want to, again, thank KCA for hosting this. I think it's very helpful. And I'm glad to have this opportunity to visit with all of you and try and help all of you understand this process a little bit better. So thank you for the invitation and for all the great work that you do.
Well, thank you very much. I really enjoyed your talk. I love the references and the pictures of birds and trees because I didn't know either one of those either. So nice to know I'm not the only one. So we'll thank you. And we're going to switch over to now talk about side effect management.